gonna see the people in white coats again. I'm trying. You know how it is, you know. Yeah, I'm gonna keep on going. Keep on going.
I hope you didn't hurt yourself.
Wow, he do it by himself.
My name is Camille. I'm from the therapy department. And as you can guess, we're here today to talk about falls in skilled nursing. How many times have we heard that phrase over the years? Each and every one of us should be familiar with it. We know what it means. Somebody has fallen and they can't get up. Falls in nursing homes are a huge issue. And a nursing home with over 100 beds reports up to 100 to 200 falls, and many falls go unreported. How serious are the falls? 10 to 20% of nursing home falls cause serious injuries, fractures. Falls can result in disability, functional decline, reduced quality of life, further loss of function, depression, feelings of helplessness, and social isolation. So today we have a little exercise for you. And we want you guys, we're going to give you a little case scenario. We want you guys to kind of figure it out with us and tell us how we can prevent falls. And I'm going to turn it over to Peggy. Everyone knows Peggy. Peggy Kaufman, PTA.
Hi guys. I just counted, there's roughly about 40 people, so if we can real quick jump into groups of five, because I've got 8 scenarios and I'm going to have you guys brainstorm interventions about how you can prevent this fall that I'm giving you from happening again. I'll say it again once you all get into your groups of 5 or 6. 5 or 6.
You're over here.
All right. You guys are a group? Okay. All right, so what you're receiving is a very brief scenario of a fall, and we want you guys to brainstorm and come up with an intervention or 2 or 3 or about however many you can, how to prevent that fall from happening again. And then we'll all get together as a group, discuss it all, and see if we can add to them. Are you guys in a group? You guys want to be in this?
Camille. 1, 2, 3, 4.
There's one more group needed over here. Pass that on here. Okay, I need 2 more groups. 2 more groups of 4 or 5. Here's a group. Here you go. Okay, come up with an intervention. You guys still need a group, right? Here, Dee, can you sit with them? Okay, this is you guys. Coming up with interventions to prevent that fall from happening again. We'll give about 10 minutes to work on it.
So you can do it together. Outside. Okay.
Okay, we're gonna break. If you haven't finished, that's no problem. Let me take yours. Yeah, I'll read them out loud, it'll be easier. So this scenario, guys, Mr. Blue was found lying on his back on the floor, still in his wheelchair. He said he sat in his chair and he felt like it started to tip backwards. He sits down very fast and he pushes back. He's got mild dementia. So interventions are to put anti-wheelchair tippers on the back, asking for assistance to get in and out of the wheelchair, leave him out in the open areas for supervision or get a sitter, get with them on education, get with therapy to educate the patient, and speech for cognition. Very good. The only other thing we thought to add maybe were just to continue the therapy for transfer training to try to get him to be able to sit down a little smoother so he doesn't back the chair up and fall. Okay? No flopping. Okay, next one, there's no answers. Okay, we'll hold off on that.
But she can explain.
Oh, okay, well their scenario is Mr. Jones was lowered to the floor when transferring to the toilet.
Oh, that's not ours.
That's not yours.
Oh, it's us.
Oh, you guys just didn't write
We
anything.
didn't get done yet.
Okay, Mr. Jones was lowered to the floor when transferring to the toilet. He is non-weight bearing on his left leg. There was a CNA with him, and he is alert and oriented ×3, so he is not confused.
First of all, I will ask Mr. Jones what his abilities are to or if he needs a lot of assistance or not. And then just make sure that the patient is aware that, you know, he has to lock the brakes and actually educate also the CNA on how he can transfer and decide that he can transfer or not. And what else? Learning.
Learning to pivot.
We also added to have 2-person assist because of the non-weight bearing. Anyone that's on 1 foot is going to be higher risk for falling because they can't stand and balance. To continue the transfer training with therapy, making sure they have non-slip footwear on, and if need be, use a sliding board. Sometimes patients that are on 1 foot are better off doing their transfer sitting, so they're at less risk for falls. All right, next one. No answers written down. You guys have? Okay. Sorry, I probably didn't tell you all to write them down. It was easier. Okay. This is Miss Polly was found in front of her bathroom floor. She doesn't remember calling for assistance before walking without her walker to the bathroom. She also said she had to go really bad and it was burning. She does have some memory loss. So interventions were toileting plan every 2 hours, making sure a patient has her walker at all times, report to the nurse about the burning, maybe the patient has a UTI. Awesome. Let's see. Yeah, bedside, these are some of the other interventions we came up with. A bedside commode. Check with therapy to make sure, first of all, she can ambulate with a walker, and if she can, to have the walker within reach, which you guys mentioned. Do the labs to maybe rule out a UTI. Okay, Mrs. Smith was found on the floor in front of her bed. She reports sliding onto the floor when she tried to stand up. She is alert and oriented ×3, so she's not confused. All right, we're going to use non-slip footwear. Something on the floor, or make sure to wear non-slip footwear. Good. Educate the patient on using the call light, and that's an important one. We can educate them on using the call light if they're alert and oriented. If they've got mild memory loss or any kind of dementia, they're not going to remember to use the call light. So we can educate and educate, but we have to come up with other interventions to prevent a fall. In this case, she's alert and oriented. Let's see. Some of the other things we could do are to make sure that the height of the bed is at a level where when she's sitting, her feet are touching the floor, and she's alert and oriented, so we can make sure that she is aware how to use the control of the bed, so when she sits, her feet are firmly on the floor, and she's not going to try to, be slipping off. Non-slip socks we already mentioned. Making sure that the bed is locked. People will try to stand up and the bed's not locked, the bed starts to move, they're going to fall. Making sure her call bell is in reach and educating her on the things that we just talked about. Okay, now her husband, Mr. Pauly, he was found lying on the floor. His left hip is hurting, and he says that he rolled off the bed from a very high height. He says he tosses and turns all night, and he is not confused. So our interventions are to lower the bed to the floor, use fall floor mats, and 2-hour checks with him. We also could give him a wing mattress if he's rolling off the bed all the time. We can put a wing mattress in place. Sometimes putting the bed up against the wall is an option, not always. Yep, low bed mats and the wing mattress. Okay, Mrs. Jones was found sitting on the floor in front of her wheelchair. She doesn't remember if she locked her brakes, however, the wheelchair was unlocked. She has mild dementia. Recommend automatic locking brakes and educate the patient on locking brakes if it's only mild dementia. And then again, transfer training with therapy and proper footwear. Okay. Mrs. Blue, hello. Mrs. Blue was sitting in her wheelchair and reached down to get her remote that fell on the floor. She fell out of her chair and she hit her head. The wheelchair rolled out from under her. She is not confused. So our interventions are to utilize a reacher.
Yeah.
Keep the table close with everything in reach. Keep her call light close so that she can call for help. Also, we could use some Velcro to attach commonly used items to the table so that things won't fall off the table. She can Velcro those on there. Front anti-tippers are the ones that go in front of the wheelchair, unlike the ones in the back that prevent the wheelchair from tipping back. This will prevent the chair from tipping all the way forward, which sometimes can help them from not falling out of the chair. Velcro, you already said the reacher. Okay, good. Okay, Mr. Smith has been more and more confused the last few days. He was found on the floor in the middle of the family room. He does not remember what happened. We're going to reinforce the use of a wheelchair or a rolling walker. Advise the nurse if there's increased confusion continues because there could be a UTI. Collaborate with staff for supervision and automatic locking brakes. The automatic locking brakes would be helpful because he is confused. He's not going to remember to lock the brakes when he stands up. Getting lab work done because he's increasingly confused, so there may be something going on with his lab. Keep him in the areas of frequent supervision. Offer him plenty of fluids because he may be getting dehydrated, and that could be causing some of the confusion too. Those are the yeah, I think we got them all.
We'd like to continue the in-service for just a little bit longer, so please be patient. We'd like to go over using a gate bell, okay? The reason for this new implementation.
We're starting a new policy that all the patients that come in are going to be receiving their own gate belt. So when the therapist is going to do their initial evaluation, they're going to leave a gate belt with that patient in their room on their wheelchair. That gate belt is to stay on the wheelchair and to be used with that patient every time you're doing a transfer or if you're walking. Keep it on the chair so when they come to therapy, they're going to have that gate belt. When they come back to you to the floor, they'll have that gate belt on their chair. If it gets soiled and has to go to laundry, we'll need to get another one from Central Supply so that they have that one with them at all times.
And now I'm going to turn it over to Cassandra. She's our student completing her level 2 field work. And take it away, Cassandra.
Well, what I want to go over, everybody has seen one of these. Can you hear me? Can you hear me? Hello?
Hello?
Yeah, got it.
Okay. Gosh. Okay, what I want to talk about first, everybody knows what is a gate belt. Oh, wait a minute.
Sorry about that. Cassandra.
I'm getting older. Okay, a simple explanation. What is a gate belt? This is a device that helps prevent anyone from falling. While walking, transferring from a bed to a chair, wheelchair or a chair, even from a car, from a wheelchair to a car. This is another assistance device that helps with prevention from falls.
How do we use a gate belt? If for any of us that don't know, well, we need a little refresher because we all do.
How to use a gate belt?
The proper way to use a gate belt is to make sure that there's no tubes, wires, anything that's going to interfere with the patient, okay? So we're going to put this on. It should be below. It should be tight enough where if the person is seated, they can get up with a little bit of a hoist. So I could actually lift the 300-pound man if I do it correctly and the gate belt is in the right position. Now, many of you, I've been doing this a long time, so you'll see people having a gate belt up here. Well, yeah, that does nothing because if you have a gate belt up here, okay, and I have her, not only are you going to hurt her private parts in some cases, but sit down like you're going to sit in a chair, my dear. Let's go in a chair. Sorry if you can't see, but you all get the right idea. Sit down in the chair. Sometimes if you're pulling a patient up, okay, where's the gate belt going to go? You don't have enough. The gate belt will go up. In some cases, you'll find a gate belt over here. Everyone has their own technique. The thing is to be safe, to be secure, to maintain patient safety at all times, and avoid falls. I'm going to go ahead and let you continue.
If you see on the pamphlet, it does sometimes say you can put it, if you can't get it around the waist, because if they're a larger person, you can put it up underneath the armpits, which some people can't get a gate belt all the way around. Oh, I'm sorry. All the way around.
One of the big reasons to use the gate belt for fall prevention is because it's much easier to grab somebody by a belt if they're going to fall than a gown that's going to rip off, or they don't even have a shirt on, you're going to grab their arm. You can grab the gate belt a lot faster and a lot more securely than you can their arm or their gown.
Yes. And always make sure when you have it nice and snug, 2 fingers. They always say check it. At least 2 finger, not so tight. And remember, because I've done it, to take it off. Take the gate belt off after using, because I've had a couple of patients that still have the gate belt on. But, I mean, we're human. I've done it still. But this is one of the main things that a lot of the CNAs should always use. I know therapy, we automatically are trained to use the gate belt, gate belt, gate belt. But I've seen a couple of cases where someone could have prevented a fall if they had the gate belt around them. They could have easily, you know, slid the patient down. You know how they tell you to slide.
You have a lot more control.
And you have
a lot more control when you have the gate belt on them.
Yeah, and what I saw, she didn't have the gate belt on. They went to fall. The gown came off, and the patient fell. So
There's just a brief there. That brief is not going to save them. That brief's going to rip in your hand, and they're going to be on the ground. So the belt is a lot more secure and safe.
much more.
Any questions or anything you guys can add to different fall prevention techniques that we didn't cover? There is one we didn't do a scenario on, is the sit-to-stand lifts. The sit-to-stand lifts are great if the person can bear weight on their legs. If you have somebody that can't stand, when they get in that lift, in about 2-3 minutes, they're going to start collapsing, and that sling's not going to hold them. So they really have to be able to stand in the lift and carry their own weight for at least 3-4 minutes. If not, they're more of a candidate for a Hoyer lift, where they don't have to stand up. When in doubt, always use a second person too. If it's somebody new and you're not sure, you're reading through the chart or getting information from your coworker and I don't know, I'm kind of scared I might not be able to move them. Get a second person until you feel comfortable with them.
Notice where you're standing too. So getting up out of the wheelchair and going to the toilet, you don't want to be behind the wheelchair. They'll just fall in between the wheelchair and the toilet and you can't reach them.
It's proper transfer techniques. Proper transfer techniques.
And if they don't have that, whichever side, because we have a lot of patients that have CVAs and have just one side of weakness, it's always best to be on the side of the weak side. Don't.
Yeah, and transfer them to their strong side. And we can always go over that with you guys if you have it, patient specific. But if they're, if their left side doesn't work real good, you're not going to want to put their chair over here because then how are they going to get there? They can't step. If you put their chair here where their strong leg is, okay, they might be leaning this way, but with that gait belt, you can kind of pull them and they can step onto their strong leg and get into the chair that's right next to them. So transferring to the stronger side can also help prevent the fall. Okay?
Thank you very much.
Okay, thanks guys.
Thank you.